Welcome to ED Day Away 2020. If you didn't already, make sure you sign in. That way you get credit for attending. As the year that keeps on giving, 2020 has provided us with some challenges to hosting our annual skills days, but we thank you kindly for tolerating this new format. Hopefully you'll learn a few things, get more comfortable with some skills, and spend a little time with your work friends that's a bit more relaxed than usual. The first new thing is that you've got the option to take this lecture with you. So feel free to go enjoy this regulatory review from a cozy spot or go outside and enjoy the COVID-killing sunshine. After this video, you'll get a 15-minute break and then be due to report to station number 1. If you don't know how to get to your first station, return to the ED and get some guidance and/or an escort. Let's get started. First, with some gratitude. Happy Emergency Nurses Week to all of you! As my good friend Exposito says, not all heroes wear capes. Here's just a few examples. See? No capes on, none of them. Plus, there's you. Talk about a superhero. Let's keep the applause thundering and give a nod to our ED rock stars from the past year. We've got the crew from La Jolla, and the crew from Hillcrest. And, of course, we have to celebrate the most pro-level rookie ever to walk the halls at UCSD, Ms. Maddie Issue, the 2020 UCSD Rookie of the Year. Amazing. Now on to today's itinerary. You're currently viewing the opening lecture. Great job. Next, you'll rotate through 3 different skill stations. One station will cover safe patient handling, restraints, and art sticks. Another station, VADS, prostacyclins, and coudes. The third station is a stroke simulation. This will also count as the only other stroke hour you need for this year. That means that you'll just take the 2-hour stroke module plus the 1-hour aspiration module on the UC Learning Center when they're released later. And boom, that's it, all done with stroke hours. You're welcome. And if you didn't get one already, make sure you have a master competency for the day. Think of this like your passport to adventure, or like those autographed books they had at Disneyland when you were a kid. Except instead of waiting in line to meet Donald Duck, you get to play with medical tools that cost hundreds of thousands of dollars, and nurses from less premier institutions only dream of getting to learn about. Take this master competency out right now. Print your name on the top, circle today's date, and circle the name of your manager. Now flip to the last page and sign at the bottom. Keep this packet with you all day. You'll get a signature from the instructor at the end of each station. Then turn it in at the last station. It will then be added to your employee file to show off how awesome you are next time the Joint Commission comes knocking. To get CEs, we have to fill out evaluations. To make things touchless, there will be a QR code that lets you fill out an online eval in a few seconds at the end of each station. Last thing about paperwork, if you didn't already, please use the QR code at check-in to fill out the demographic survey. This helps the department update your file and also helps management track when people get their schooling and earn new degrees. So that's what your next 4 hours is going to look like. I know, I'm super excited too. Why do we have a skills day every year? This lecture is presented each year to cover mandatory regulatory content. Then we do hands-on with all the special equipment that we need to care for all our unique patient populations. But mostly we come together to spend time with each other and remember old friendships and forge new memories. We're also here because UCSD believes in the Joanne Duffy caring practice model of nursing. And that means it's important to the institution that we, utilizing frontline leaders, disseminate new knowledge, innovations, and improvements so that we can all display exemplary professional practice, which ultimately improves patient outcomes. With some crossover ideas, we also use the starfish model because San Diego is all about the beach and things, and training sections like the ones you'll go through today encourage professional development, share new research and innovations, and create a healing environment where patients and staff alike feel cared for, which all leads to stellar outcomes. Get it? Stellar? Because it's a starfish? Too good. Speaking of professional development and earning some dollar bills, y'all, Wilmar is still buying vouchers for anyone that wants to take the CEN exam for a drastically reduced price of $195 instead of the usual $370. Why get your CEN? Looks mighty good on a resume, and you get paid education time for studying if you pass. And you get an extra $1,080 added to your pay each year. Take it to the bank. On to the regulatory stuff. Updates are shared at both sites via pulse points, which is sent out via email and posted to the DES board. What's the DES board, you ask? In addition to being a thing to look at during huddle, it's a system used across the health system to celebrate successes, align practice with organizational goals, and identify issues. On this last point, the idea is that you, the person actually doing the work, has a place every day to identify things that might prevent you from giving excellent care. Then you can solve them with a team powwow, or if it's a bigger issue, send it up to management because they have their own DES huddle immediately after yours. Now, let's talk core measures. As comprehensive stroke centers at both Hillcrest and La Jolla, the stroke care we provide is phenomenal. Always trying to improve, these are the metrics we can target to improve patient outcomes. Door to CT, door to TPA, the patient passing a swallow screen before anything PO, including meds, compliance with neurochecks and vitals post-TPA. These are done Q15 minutes for 2 hours, Q30 minutes for the next 6 hours, and then hourly for the following 16 hours. Also, all new diagnoses of stroke or TIA must receive education about their risk factors prior to discharge. For us in the ED, this means that on the rare occasion you're discharging someone who was diagnosed with a new stroke or TIA, whether to home or a SNF, they must be provided with this education before they leave the ED. You'll get to dive deep into the finer points of stroke care during the stroke simulation later today. STEMI is another area of emergency care where we shine. Routinely, we post door to cath lab times in the sub 20-minute range. Want to be the next record holder? Here's what you need to do. Our goals are door to EKG within 5 minutes, EKG to cards call within 5 minutes, transport to cath lab within 10 minutes, and an overall door to balloon of 90 minutes or less. Key components of STEMI care from the ED perspective are getting that EKG done immediately, putting the patient on the defib so they're ready for transport and you're ready for a potential arrest, 2 large bore IVs, at least 1 with trifurcated extension, attaching the cath lab wireless leads, and ensuring the patient has been consented by cards. Whittling down all these times can mean your next STEMI patient has coronary perfusion restored sooner, and you'll be the new ED STEMI champ sporting your own Corona? Too soon. Moving on. Sepsis. Wow, there is really not much that you all aren't incredible at. This one is nuts though. Out of the whole nation, UCSD is consistently ranked in the top 10 for sepsis performance, and we're currently number 4 out of everybody. These slides were provided by former ED nurse and current sepsis quality queen, Kristen Bray. Let's see what she's got for us. There's a new mnemonic, say that 3 times fast, in town, and all the cool kids are saying it. Defeat sepsis. Remember this, and you'll be sure to document, recognize sepsis early, give an adequate fluid bolus, remind the doc to re-evaluate after their bolus, advocate for pressors if the patient remains hypotensive after the bolus, which means a systolic of less than 90, MAP less than 65, or a drop from initial systolic BPs of 40 points or more. And lastly, you remember to do all of the initial bundle, labs, lactate, blood cultures times 2, plus IV fluids and antibiotics within 3 hours. But of course, fastest is bestest. Here's how our compliance looks for the past several years. What do you see? Both sites are right around half compliance. Wait, that's not that high. 50% compliance gets you 4th place? Yes. Isn't that nuts? Just imagine how excellent our sepsis care would be if we got up to 80% compliance. Enter the sepsis narrator. You've become familiar with this new tool, and hopefully it will push our numbers up even higher, which means better patient outcomes. Time will tell, but the first data will be available in just a couple of weeks to see if it's helped so far. No matter what, Quality really wants to thank the unit champions and leadership, but most of all of you, for tackling each septic patient with gusto and making sure they have the best care possible. Now on to regulatory topics. EMTALA is the anti-dumping law. It was implemented in the 80s to prevent EDs from turning away critical patients, including those in active labor. What it means for us is that every patient that comes to our ED must have a medical screening exam by an ED provider. This is not a nose-to-tail workup, but an assessment of any immediate threats to life and treatment for any of those. If a patient presents at a hospital and that hospital can't provide the treatment the patient needs, then they can be transferred, but only if the benefits outweigh the risks, the receiving hospital physician has accepted the patient, the appropriate level of personnel and equipment is available for transport, all paperwork, EMTALA, transfer paperwork, and a copy of the chart go with the patient, and the patient consents to this transfer. Triage. Triage is the first assessment of the patient condition, and it's used to anticipate how sick the patient is. Like most everybody, we use the ESI scale. Importantly, the ESI scale is based on acuity. You start at the top and determine if the patient needs any life-saving intervention. This includes CPR, but it's not just the actively coding patient. Ones can also be someone who needs critical airway support, pulse ox less than 90%. Any emergency medications, think TPA, adenosine, D50, anything that you find in a crash cart. Also, acute mental status changes, anyone unresponsive, and anyone that will die if you didn't do something or give them something right away. Level 2s aren't quite as sick as 1s. They might have chest pain with EKG changes, but no ST elevations. They may have shortness of breath, but their pulse ox is above 90. These are people in severe distress, one that you don't want sitting in your waiting room for any amount of time. Level 3s are where we switch to using resources rather than acuity. All level 3s should have stable vitals. They need a bigger workup, meaning 2 resources or more, but their vitals are all within normal limits. 4s just need 1 resource, an x-ray but no IV or IM meds, a blood draw but no IV fluids, a simple lac repair. And then 5s require no resources at all. Arguably, they could have just gone to primary care, but they're here for a refill or a doctor's note, but that's it. Expediting throughput can start in triage by using the complaint-based order sets. These are doc-approved orders that are complaint-specific. Use them after triaging so that the patient doesn't just sit and wait. Things get cooking right away, and then by the time the doc examines them, results are back and they're ready for DC. Next case. Left without being seen patients are divided into 2 categories, those that leave before triage and those that leave after. If a patient leaves before triage, call the patient 3 times, document, and dismiss. If the patient has already been triaged, though, we need to do more. We have to call 3 times, each 15 minutes apart, attempt to reach the patient by the phone number in their chart, notify the ED attending because they have to follow up on the results of any orders that were collected, and of course, document all of this. If a patient has been registered and wants to leave before being seen, notify the ED provider so they can have a face-to-face and discuss the risks of leaving. In La Jolla, escort them to Chair M for this discussion to take place. AMA, or leaving against medical advice, is a patient that has told you they want to leave. Tell the doc, again, so they can explain the risks of leaving. Then the patient can sign or refuse to sign the AMA form. The doc, and you, can at least provide verbal discharge instructions. Elopement is like an AMA, but different. This patient just bailed. You didn't even have a chance to say goodbye. Upon finding that your patient is no longer, tell the charge and attending. Search for the patient, call them, and notify security. If the patient lacks decisional capacity, the police must also be notified. This is a big deal. We just lost a person, so you have to write an I-report. A proper discharge is a super important part of ED care. Discharge must be in the patient's preferred language, unless you're certified bilingual. You should print the AVS. It's also a nice touch to highlight the most important bits, and always double check that the patient's ID matches both the AVS and the prescription. As nurses, we are all mandated reporters. This means we must report any suspected child, elder, dependent abuse or neglect, and any suspected assault. These groups are defined as a child is less than 18, an elderly person is 65 or older, and a dependent adult is between 18 and 65, but has physical or mental limitations that keep them from caring for themselves. Or someone who is in a 24-hour healthcare facility, like a SNF, but also including a hospital, like the one you work in. Which means that we are mandated to report any abuse, neglect, assault that occurs while we're caring for any of our own patients. Reporting is everyone's responsibility. The ED social worker can be your best resource. Make sure to file a police report in the city where the suspected event occurred. Interpreters must be used for all critical conversations. These include triage, consents, new diagnoses, complicated diagnoses, prognoses, treatment plans, and discharge. Approved interpreters include someone from Interpreter Services, a MARTI, Blue Phones, Extension 171, and staff that have passed the phone exam for their normal work and their patients only. Family, however, can only be used to explain routine work like checking vitals and cannot be used for any of those critical conversations we just listed. A minor can never be used to interpret. To screen for suicide, nurses perform the Columbia scale. Questions are asked exactly as they are written. This screening can trigger the initial level of intervention. The provider then performs an assessment. This more detailed exam can upgrade or downgrade the level of interventions. For sitters, we have two confusing categories. Thanks, Joint Commission. A sitter up to 1 to 3 is called continuous observation. A sitter that is 1 to 1 is called continuous direct observation. Falls. Falls are a never event, which means they should never happen, but they do, so how can we stop them? Using these interventions can help. Plus, after any fall, a debriefing should occur, which doesn't blame but tries to see how future falls for this patient or any patient can be prevented from happening again. Every fall requires an I-report. And finally, as long as we're getting excited about I-reports, every code needs one too. Entering an I-report for each code helps us improve our resuscitations. And, oh no, what's another thing we're super good at? Yep, resuscitating people. You deserve credit for your reanimation, so file an I-report after every code. Just a quick S-bar that says what happened.
Bringing people back to life is noble work, but it's all for naught if that resuscitated patient ends up dead or disabled due to reperfusion injury. This is when tissue, important tissue like that of the heart and or the brain, goes without any or much oxygen during an arrest. In response, the mitochondria start panicking and breaking down. They flood the area with calcium and reactive oxygen species. Your team is dialed, delivering expert chest compressions and stellar execution of the art algorithm. So, of course, you get the patient back. But now, as those cells start coming back to life, they're trying to bring their machinery back online. But they're in a soup of hazardous chemicals. If they rev up too quickly, they suck up all this calcium and oxidants, and the cells are killed anyway. So what do we do to tell these just safe cells to slow their roll? Targeted temperature management. Here, we keep the patient from revving up their cellular metabolism, keep things low and slow. This means the body can clear all those harmful chemicals and slowly let their cells get back to doing cell things. Now that the patient you saved has a remarkably better chance of walking, thinking, living their life post-code. So ROSC is great, but ROSC also means TTM. Our job in the ED is to get started cooling right away, get things going. That will stop fevers. Then the specific temperature can be dialed in down the line. Start with ice packs immediately. Then ask the providers how they want to continue cooling, Arctic Sun or Thermogard. TTM is not a contraindication for surgery, including cath lab or ECMO. Just make sure it happens and give your patient a chance at a meaningful outcome. You save them, make it count.
All right, that's it, the end of the beginning. Thank you for hanging in there. Next will be the fun part, the hands-on. Remember to complete an eval for each station and get a signature from the instructor. But first, enjoy a break for the remainder of the hour, and just make sure to get yourself to the first station ready to start on time. If you're lost and don't know where to go, return to the ED and get pointed back in the right direction.